Hello everybody and welcome to our presentation today. My name is Anne Free. I'm the Medical Director here at the Waukesha Employee Health and Wellness Center. You should all probably know each other as the main stakeholders in this organization. We have their representatives from the county, city, and school district, as well as our corporate heads here from HealthStat. What I'm here to talk to you today is about a quality improvement initiative that we here at the clinic would like to implement in order to create a healthier employee base, as well as work towards the performance guarantee set out by the organization. A few of the things that we're going to cover today are a review of those performance guarantees, the introduction of a diabetic registry and what that is, and how ideally this will work to achieve the goals of the performance guarantees and the health of our employees, and what those outcome goals might be. To start with, let's review again what the performance guarantees are. As part of HealthStat's contract with the city, the county, and the school district of Waukesha, they have set forth a certain number of goals that need to be achieved every year in order to create the guarantees that they've put forth. Every year, they have the same few guarantees, including after-visit surveys, corporate performance, and the ability to reduce the risk factors through our HRA lab results. However, every year we also add in 2 clinic-based goals that alter depending on what we are looking for the year. In the past few years, we have looked at performance guarantees to ensure that our mammograms are being ordered and delivered for our women every other year, that diabetics have been having at least 1 hemoglobin A1C drawn per year, that we have been referring people to our EAP program for depression and anxiety, and that office visits are also then faxed to the PCP afterwards. Our performance guarantees are often decided by our clinicians. However, part of this is also influenced by the claims data that gets run through HealthStat's reporting. Routinely, we see that diabetes falls into the top 5 diagnoses in that claims data, and our clients have made it clear that they want us to focus on diabetes control, prevention, and closure of gaps in order to keep their employees more healthy. Our diabetes-based performance guarantees have been numerous. Last year, we looked at the yearly hemoglobin A1Cs that were drawn. The year prior to that, we focused on trying to catch people with pre-diabetes, reaching out to those who had glucoses of 100 to 125 on their HRA exams. This year, our performance guarantee for 2018 is to make sure that everyone with a diagnosis of diabetes has had a yearly microalbumin check. The reason for the microalbumin is to check for organ or end organ damage that can occur in diabetes, and in particular, this would be affecting the kidney function. Again, per our clients' recommendations, they would like probably one of each of these 2 performance guarantees of the clinic to be based on diabetic care for each of the upcoming years as we continue to move forward with this. In order to make sure that we get the highest quality data as well as accurate data, we have decided to create a quality improvement initiative to focus on this. First, we want to identify the topic of interest, which of course is to create better health for our patients, employees that have diabetes. We need to develop the measures that we will be using the American Diabetes Association, otherwise known as ADA. We use the guidelines they have for diabetic health. This includes preventative recommendations, immunizations, lab results, overall monitoring, medications, and so forth. Finally, we want to be able to design a data collection system in order to get the information that we need. For this, the plan is to create a diabetes registry for the Waukesha Employee Health and Wellness Clinic, in which we can store all this data and be able to access it easily and keep it up to date as much as possible. In order to create the diabetic registry, again, we are using the American Diabetes Association guidelines. There are multiple guidelines that are out there ranging from anywhere from lifestyle changes to medication to preventative health. A few of these are that diabetics should have yearly eye exams. They should have that yearly microalbumin test. They should have a yearly foot exam. There are specific lab tests such as cholesterol and kidney examination with using a creatinine that need to be tested on a regular basis. Certain immunizations need to be done for diabetics, which otherwise wouldn't be recommended for the general public based on age. And again, then cardiovascular risk control, as we know that diabetes already puts people at a higher risk of cardiovascular disease. Having other risk factors would amplify that more, and we need to control them as much as possible. So the question then becomes, how do we keep this all straight with so much data floating around? Part of what we plan to do then is to create this registry using the FADE method for quality improvement. What this means is that we are going to focus and choose a problem and write a statement to describe it. We're then going to analyze that problem to learn more about it by gathering information such as performance data. Hopefully then we can sit down to develop a solution for the problem and then a plan for implementing that solution. And finally, we will execute and evaluate. We're going to implement that plan, we're going to monitor the results, and then we will adjust based on that information that we gather. In order to do this, we're going to create a team of dedicated people within the clinic and the surrounding area in order to get to this final goal. The team members will likely be our sponsor with our corporate members. Travis, who is our clinic liaison, will become the liaison also for this project. They are the ones that help create the contract and performance guarantees. They're also the ones that have the financial vesting associated with this as well. The team leader will be myself as the medical director, having the medical knowledge of the guidelines that need to be tracked, as well as understanding of how clinic flow works. We will hopefully have the medical background to be able to achieve this. We'll also use a facilitator as Courtney, who is our office manager. Her main goal within the clinic is ready to lead and delegate. She's also the one that creates schedules and can help set times for meetings and for workarounds as well. Finally, we need to involve all team members who are part of this clinic, including our physician assistants, medical assistants, receptionists, health coaches, as well as our corporate data reporting team, IT services, and our eClinicalWorks, which is our electronic medical record leader, who is Tucker McKay. Let's focus a little bit more then on where we're going with this. So again, the F of FADE is focus. Our problem is going to be improving the care of our diabetic patients while also meeting our performance guarantees put forth by the contract. In order to do that, we need to be able to track labs and preventative care measures accurately and timely and create a solid base for where these are going to be stored. We're going to need to analyze this data. The main goal here will be to be able to run a report using the information that we can gather from our electronic medical record as well as our claims data, and specifically for each of the measures we're going to use. Our denominator will be anyone who has an ICD code of diabetes, and thus all that information will be pulled from those particular patient charts. We'll look for the lab information such as the LDL, microalbumin, BNP. We'll try to get the latest blood pressure reading from the most recent office visit. We'll look for any additional ICD-10 codes for cardiovascular disease. We'll check and see what immunizations are already recorded on the chart. And then we'll also try to pull claims data for other outside sources, such as ophthalmology referrals, podiatry appointments. Perhaps they had outside labs done as well. As we analyze, we need to keep on asking why. Why are we missing some of this information? Is it because the patients are getting care from outside providers? Is it information labeled differently and thus we're not able to easily see that and pull it into our EMR? Are patients not getting the care that they need? Maybe providers not ordering the tests. Maybe it's too complicated to find these outside specialists like the ophthalmologist and the podiatrist. Maybe we aren't following up on the referrals to make sure that they have gotten them taken care of, as maybe the patient forgot or didn't understand what we were asking for them. We'll also use our team meetings in order to help continue to analyze these issues. We'll have our core team, which will mainly consist of our medical director, sponsor, and facilitator, to get together weekly and go through some of the nuts and bolts of things and then start to delegate tasks out as needed. We'll have the entire team meet together every 2 weeks for the first 2 months as we start to get the project off the ground, and then hopefully every month thereafterwards to continue to improve and monitor our results. We'll plan an agenda to be distributed prior to each meeting so that everybody comes well prepared with their tasks completed and mission at hand. The D part of the FADE process is to develop, and this will be where the majority of our work will come into play. We need to create this registry for our patients that have diabetes that will plan to be reviewed on a quarterly basis to make sure our metrics are up to date. What our main goal will be is to decide how we're going to house this information in what form. We need to be able to see if we're able to capture all the data that we need within our EMR with the EMR tools. There is a registry tool already within our ECW data, with our ECW medical record, however, is not currently turned on. We'll have to see if by turning it on and trying to pull the information we want that we're getting the information we need. If we're unable to have this be successful, we'll likely need to create our very own SQL database that we can specifically enter the information that we need, but most likely on a manual basis. We'll need to, again, then decide if the information that we gather can be pulled electronically, or if we do have to be manually entering, maybe we need to pull from multiple data sources, such as the Wisconsin Immunization Registry, maybe from outside providers, the claims data, the EHR, and decide what information is the most important. Finally, we're also going to need to find a way of how we're going to create prompts in order to address any of our gaps in care. Is this going to be done at the office visit when the patient is present? Will we be making outreach phone calls? Are we going to be sending out letters? Are we going to hold events? All this will need to be discussed once we see where our gaps in care are and the best way to manage those. As a group, we're going to need to discuss what is the best way to record that info. Does it need to be on paper? The goal I believe we'll start with is to create checklists that do have each of these goals. And for each diabetic patient that comes in for visits, we'll fill in that paper and then visually see right at that office visit what they are missing. Hopefully, with this information directly in front of us, we can close those gaps of care directly while the patient is present. But we can also then use that information to check against what our registry might be pulling electronically and see perhaps where we might not be getting accurate data pulls. As we work through the different roles of the people in the clinic, we can see that everyone does have a piece of this puzzle. Our receptionist will hopefully place that checklist we just talked about on our clipboard that travels with the patient throughout their visit so that we know the patient has diabetes. This will then alert the medical assistant and provider that they need to be looking at these additional problems. After the visit, the patient always checks out with our receptionist. At that time, it will be their job to make sure that they do come back in for any labs that are needed and that they make that next office visit appointment in likely 3 to 6 months. Our medical office assistant will perhaps place a checklist on the clipboard if the receptionist does not know if they're diabetic or not. Each of our medical assistants will take all the vitals, including the blood pressure, but they also go through everybody's list, including their medical history. And if diabetes is one of the codes on there, they'll make sure to address this and make a note of it. They are also always putting on the immunization records for every patient, and we'll look to see if all our diabetic labs are taken care of, and perhaps last time they came in for labs as well. They'll update the chart and registry after each visit using that checklist and entering the data appropriately. Finally, as the clinician sees the patient, they'll assess for gaps in care and order any labs, immunizations, and referrals that are needed based on those gaps. They'll be the ones that can perform the diabetic foot exam and decide if a referral to podiatry is needed or not. Review the medications will determine if they're on appropriate medications. And then again, any referrals that need to be done can be done through that appointment as well. And then updates to the chart can be done as they are working through the visit and afterwards as well. Finally, we're going to completely execute this plan and evaluate. Once we have all of our pieces in place and everybody knows their roles, we can start implementing this checklist as well as having the diabetic registry created. Hopefully, through our analysis, we'll determine what pieces might be missing, and we can do some tweaking and alterations to make sure we're pulling the data that we are needing to see. We'll pull an initial run to see where we stand prior to making any gap closures or adjustments to our infrastructure. And then after 6 months, we'll make sure we rerun this report and see if we have any additional improvement or if we're still having needs and gaps that need to be closed.